Thank you for this opportunity to present this lecture on gait analysis without a lab. I'd like to thank my partner John Davids at Shriners Hospitals for Children and colleague Suzanne Bratkovich, who collaborated with me on the development of this presentation. We had an opportunity to present a 2-hour version of this course at the CP Academy in 2017. I hope you'll enjoy this 10-minute teaser. There are no disclosures relevant to this presentation. We've created a website for more information. You can download the slides for this presentation, worksheets for observational gait analysis, and instructions on the use of the mobile app featured in this talk. Gait analysis without a lab is best labeled as observational gait analysis. OGA plays an important role in documentation and objective scoring of gait when you have no access to a three-dimensional gait lab, are looking for frequent documentation of gait pattern changes, such as after surgery, and a child cannot cooperate with a full three-dimensional gait study, such as children who are very young, less than age 5, or who have behavioral or cognitive issues. Refining your observational gait analysis involves using technology to improve your observations, as well as having a structure for your observations. Let's talk about the technology first. High-quality video is your key to observational gait analysis. Good observations take time, and that's one resource you don't have in a busy clinic. Obtaining high-quality video will allow you to take this important decision-making tool out of a busy clinic. Cameras embedded on your mobile device have improved substantially in the last 5 years, allowing you to obtain high-quality video very conveniently. This high-quality video should have ideal adequate lighting, a background with minimal distractions, and enough distance from the subject to view the entire body with adequate perspective. I'd recommend at least 20 feet for coronal and 15 feet for sagittal video to allow for the best perspective of the patient. Anyone can get coronal video in a clinic hallway, but high-quality sagittal video is your key to high-quality observations. As you'll see later in this presentation, most of the quantitative visual assessments of gait are obtained in the sagittal plane. The best sagittal video is when the camera moves with the child with minimum motion artifact, as in this example from our gait lab, where we used a video camera on a trolley. This allows for in-plane visualization of more than one stride of gait, allowing you to see both limbs without the problems of parallax. So now you must be wondering, you want me to get a trolley in my clinic? It turns out that handheld stabilization for mobile devices has become much cheaper in the last several years. The same technology that allows for smooth videos on drones can now give you smooth, image-stabilized, handheld sagittal video with technology called a gimbal. A gimbal is a platform that maintains orientation in space despite inclines or rotation. As you can see in these two images, adding a gimbal allows for smooth video, and this can cost you anywhere between $50 and $300. Visual assessment of gait relies on seeing anatomic segments with appropriate detail. Your patients should ideally be dressed in a swimsuit or bike shorts and have skin markings on important landmarks that can enhance your ability to make objective assessments of rotation and alignment from the video. While your built-in mobile device video editor has some limited functionality, sports performance video analysis apps now allow for enhanced features. There are several free and low-cost options available to you, and I've listed them here. I'll highlight the Huddle Technique app and its features. The Huddle Technique app allows you to organize your videos by title. Once you've selected the video, you can put it into slow motion and zoom in for better detail. You can use the dial on the bottom of the screen to go backwards and forwards on the video with ease. And you can compare videos, moving them separately to position the video in the exact same point in the gait cycle for both videos. You can then lock the videos together and play them simultaneously, using the dial on the bottom of the screen. To add additional objectivity to your assessment, you can measure angles using the annotation features. While technology is cool, structuring your observations objectively will allow you to take your observational gait analysis to the next level. A recent review has shown that the Edinburgh Visual Gait Score, designed for the assessment of gait in children with CP, is the most comprehensive of the scoring systems. The Edinburgh Visual Gait Score involves 17 observations per limb, 10 joint angle assessments, and 7 gait phase timing assessments. All 6 major anatomic levels are scored in 3 planes of motion, which include a total of 12 stance phase items and 5 swing phase items. To improve the utility of the EVGS in clinical practice, we've developed a scoring sheet and a tabulation sheet that centers around 4 sagittal video stops and 2 coronal stops per limb. You can find these tools on the website. Let's go through this example to demonstrate the EVGS scoring system. This is a young girl with right spastic hemiplegic cerebral palsy, GMFCS level 1. In her preoperative video, you can see she has a typical equinus gait pattern on both limbs. The right side has a contracture, and the left side has no contracture. One year following Achilles tendon lengthening and plantar fascia release, she has improved heel contact on the operative side, but does have a stiff knee. At 2 years after surgery, her stiff knee has improved. Using the EVGS to structure your observations allows for even more detailed analysis, as I'll demonstrate. In sagittal initial contact, we can see that there is abnormal foot contact and increased hip flexion, but the knee position is within normal range. This results in increased scores in the corresponding fields, circled here. In sagittal midstance, we see moderate forward trunk lean and no heel contact, resulting in elevated scores in both of those categories. Notice that pelvic rotation in midstance is normal. In the coronal plane, mid-stance from the front, there's upward pelvic obliquity on the right, but normal knee progression angle and normal foot progression angle, with no significant lateral trunk shift. In coronal mid-stance from the back, there's a moderate hindfoot varus. Moving to terminal stance now in the sagittal plane, there's marked ankle plantar flexion, but normal peak hip and knee extension. Finally, in sagittal terminal stance, the peak knee flexion is reduced, and the maximum ankle dorsiflexion is severely reduced, or there's severely increased ankle plantar flexion. These numerical observations can then be transcribed to a chart that organizes them into the phases of the gait cycle and the segments of the body. This allows us to see that while there are minor deviations in the trunk, pelvis, hip, and knee, the majority of the deviations are in the foot and ankle. Similar objective scoring can be performed on the left leg at these same 4 points in the gait cycle. This assessment shows us that all of these deviations are in the foot and ankle, and are presumably secondary compensations for the primary contracture at the foot and ankle. The EVGS becomes even more helpful in refining our observations at the 1 and 2 year points. On the right side, we can see that all of the deviations in the trunk, pelvis, and hip have resolved at the 1 and 2 year points. At the knee, we notice that the mid-swing knee flexion actually worsens at the 1 year point, which we observed with the increased stiff knee gait, but then is back to baseline by 2 years. Finally, we see that the primary deviations around the foot and ankle have resolved after the surgery. On the left side, we see that a new deviation has occurred, forward trunk lean, at 1 year, but this has resolved by 2 years. The compensations around the ankle have resolved after the surgery. But a new deviation of premature heel rise in mid-stance, also known as vaulting, has occurred at the 1 year mark. By 2 years, however, this compensation has resolved. The EVGS total body scoring grading also allows you to see that the deviations in gait have improved between time points. While observational gait analysis does allow for objective scoring, it's not a replacement for three-dimensional gait analysis. A recent study at DuPont found that the EVGS had less reliability for the proximal anatomic segments, namely the hip and pelvis, compared with more distal segments such as the ankle or foot. This is likely due to the difficulty of assessing surface landmarks in these proximal segments. Less experienced observers also had less reliability. In addition, the assessment of children with more severe functional impairment as assessed by the GMFCS was less reliable. Finally, agreement between observers and with 3D gait analysis was modest. Further studies will be required to test the limits of this technique of gait assessment and assess its correlations with functional outcomes. Just as with heart function, where increasing patient complexity requires tests with increasing precision, the assessment of gait function requires more precise tools as the complexity increases. It's my hope that the tools I presented in this talk will help you migrate your gait assessments from a simple hallway examination in clinic to a structured observational gait analysis using technology and a structured scoring system. Thanks for your attention, and please visit our website for more resources.